Good morning, everybody. Dr. Prathmesh Jain from Ahmedabad, and we will be talking about personalized solution for musculoskeletal pain. Now, in this lecture, we have actually summed up all the personalized solutions for musculoskeletal pain, and we will be focusing on some specific sites like shoulder joint. Now, this class will include introduction to musculoskeletal pain, understanding the personalized solutions, pharmacological interventions in chronic musculoskeletal pain, assessing and diagnosing the musculoskeletal pain, and we will present a case study on chronic pain with personalized treatment strategies. Now, musculoskeletal pain is a challenging condition both for patients and physicians. Now, many adults have experienced one or more episodes of musculoskeletal pain, sometimes in their life, regardless of age, gender, or economic status. Now, inadequately managed musculoskeletal pain can adversely affect quality of life and impose significant socio-economic problems. Now, approximately 47% of general population will suffer from musculoskeletal pain. And out of this 47%, approximately 40% will need a long lasting treatment for the musculoskeletal pain per se. Now, not two people are exact. So if there are different patients, different patient profile, different pain profile. So all these patients behave differently when we talk about musculoskeletal pain. So some patients with the same amount of problem, they will have very high amount of pain. Some people have low amount of pain. So let's give me an example. So there is a condition in shoulder joint that is called as a rotator cuff tear. And in a rotator cuff tear, the pain is much difference of the size of tear. Sometimes patient has a huge, large, massive tear and he has no pain. Whereas in some patients, it's a very small tear in the rotator cuff, but the pain is very sharp, very high. So it is very different from patient to patient. Now, personalized approach to therapy of pain is very important, and we'll be discussing that in detail. So, when we talk about personalized solution, uh, we need to understand what all options are available with us and how can we use these options for the benefits of patients in large. So the main challenge here, as we all know, is variability in the patients. Some patients will respond very well to pain management. Some patients will not respond very well to pain management. Now, rationalized, personalized management takes into consideration both the patient profile, the drug profile, the pharmacogenetics, the pharmacokinetics, and comorbidities of the patients, along with other medications and other conditions that the patient is taking. You must listen to the patient, understand his problems, and see what we can do best for the treatment of his pain. Now, most important is identify and clarifying the issues with the patient. You need to discuss with them, you need to discuss options and uncertainties. You provide the information about the benefits, harms, and uncertainties of each option. You need to check that the patient and professionals have a joint understanding of this problem. You need to gain feedback, you need to get the reactions of the patient. You need to agree in the course of action. You implement for a chosen treatment, you arrange a follow-up, and then you evaluate the outcomes. Now, a variety of pharmacological approaches are available, and we should know it and you should discuss it with the patient. Now, there are three main parts of analgesia. One is a non-opioid analgesics. Basically, these are NSAIDs. Then after that, these are opioid analgesics. These are strong analgesics, but they have their own part of side effects. And then we have an adjuvant analgesics. Now, non-opioid are the mainstay of my treatment of pain. So, in all patients who are having pain coming to me in the OPD, I will always give them non-opioid analgesics. The main part is acetaminophen, that is the paracetamol. This is the safest analgesia, but this is less potent. We can give it in patients who have chronic pain and osteoarthritis. NSAIDs are the most important analgesics and anti-inflammatory agents that we use in our practice. They are three types: non-specific NSAIDs like diclofenac, aceclofenac, ibuprofen, COX-2 selective inhibitors, and topical NSAIDs. Now let me talk about shoulder pain per se. Now shoulder pain is a very common thing that I see in my practice. So you can give them local analgesia, like you can give some gel. You can give them like Nicoxia gel. You can give them oral tablets like oral Nicoxia. You can give them sublingual analgesics. You can give them patches. The patches are available. Patches are available for both NSAIDs and as well as opioids like a buprenorphine or bubilon. You can give them intra-articular injections or subacromial injections. And then you can give them arthroscopy. Now, arthroscopy gives the actual relief of symptoms. It will not relieve the pain per se, but it will relieve the problem per se. So, like this is one of the patient in which there is a rotator cuff tear. And what we are doing is we are operating the rotator cuff tear with a tape lock technique. So this problem will actually cure the pain permanently. This is not a short-term solution of pain. It is a permanent solution that we are seeking for the pain. So whenever we are doing this, we are actually treating the main pathology or main problem. So we are treating the main problem. So if there is a rotator cuff tear, we repair the rotator cuff tear, the patient's problems are solved. So it will improve or it will treat the problem per se rather than treating the pain only. So this is an arthroscopic rotator cuff repair. This is a wonder surgery for shoulder pain. So this is a permanent sort of solution that we see for shoulder pain problems. Okay. Now opioids. Opioids are different opioids which are available. Now opioids have a problem. They have a habit forming issue. So you cannot give them for a long time. So you can give them, you can give patients opioids like very basic opioid is a tramadol, and then you can you have buprenorphine, like I was talking about Buvalor patch. Then you have morphine, which is very potent. So these are very potent analgesics, but they have some issues like they have issues with constipation. The patient will have constipation. The patient will have addiction. The patient will have habit forming thing, which is usually, so these are we using only in chronic pain syndromes like malignancies, cancer. So that's why not as a routine use. So only 5 to 10% of my patients, I will give them opioid analgesia. We know that the dependence may range from about 3 to 26% in patients who are using opioids for chronic pain. Now, adjuvant analgesics, these are important. So you can add with neuromodulators like gabapentin, pregabalin, carbamazepine. Antidepressants have a very good role. So you can start with tricyclic antidepressant, amitriptyline or noramitriptyline. Musculoskeletal agents with a muscle relaxant property like diclofenac, thiocolchicine, tizanidine, and cyclobenzaprine. You can take them. Anxiolytics, alpha-2 adrenergic agonist like clonidine. It reduces the blood supply. So it's again very good. We infiltrate clonidine in surgery sometimes. You can use topical agents like a lidocaine patch. So that will relieve the pain in that particular area. Now, this is the updated UHO pain ladder system. So step 1 is inclusive of non-opioid analgesia, that is NSAIDs. If the pain is there, you start with weak opioids like tramadol. Step 3, you need to start with interventions. Like I was discussing injections, I was discussing arthroscopy. So you can discuss with the patient interventions. Arthroscopy is very good intervention in knee and shoulder problems, knee and shoulder pain. And step 4, you will give strong opioids like morphine. So whenever the patient is in severe pain, malignancy, cancer patients, then you will give them opioids. Now, etoricoxib is a very novel, potent COX-2 inhibitor, which is very good drug for treatment of chronic pain, and it is very safe. So, it is a COX-2 inhibitor. It is found in inflammatory cells. It is found in tissue damage, synovial, epithelium, etc. It is a selective cyclooxygenase 2 inhibitor. It has a low risk of gastrointestinal toxicity as compared to any traditional NSAIDs like diclofenac or aceclofenac. Now it improves the osteoarthritis pain relief, joint function, and quality of life in elderly patients. If you see before and after etoricoxib, the pain, disability, and stiffness are much better. So it has got a very potent role in treatment of chronic pain like osteoarthritis of the knee. Now, etoricoxib plus thiocolchicine. So this is a etoricoxib, which is NSAID, and this is combined with a muscle relaxant like thiocolchicine. So we call it a Nicoxia MR. So this is a very good drug for treatment of pain associated with spasm. So in the back pain, in the shoulder pain, in the trapezitis, in pains which are associated with spasm, like hamstring spasm, like abdominal spasm, like back spasm, neck spasm, shoulder spasm, it is a wonder drug. So we are using it very often. We are using it on a very routine basis. And these will have a very good results in treatment of pain associated with spasm. And this is a study which shows that it has got a very good relief. This combination will give you a very good relief. Now, assessing and diagnosing musculoskeletal pain is important. You need to see the patient, do an examination, assess the severity and the location of the pain. So what we need to do is you need to assess the severity, onset, location, duration, chronicity, provocative and the relieving factors, predominant pain mechanisms, and any other associated problems. You need to communicate with the patients. You need to give a therapeutic alliance, empathy, and nocebo prevention. You need to have a specific assessment of pain, like you need to see physical assessment of the pain, predominant pain mechanism, observation, range of motion and muscle performance, palpation of the patient, specific assessment, and specific tests. Now, you need to individually report the back pain. So this is basically a chart. You can actually give marking according to this framework. Now I'll be presenting you a case study of a chronic pain. It is a 60-year-old female patient, about 5 feet 7 inches in height, and he has a history of back pain, knee pain, and hand pain. There is a morning stiffness. Pain is exhibited by movement. The pain is about 4/10 normally, and it increases to 7/10. The pain has slowly progressed over the past 24 months. There is no significant past history. There is a surgical history of cholecystectomy. All other histories are negative. Now, in her case, Tinel's test was positive. We have Heberden and Bouchard nodes, which are suggestive of osteoarthritis. There is a tenderness on the lumbar back. There is no scoliosis or kyphosis. The right knee range of motion is limited with the strength of 5/5. Right hip, the strength is 5/5. SLR are normal on both sides. Now, polyarticular joint pain is there. So you have the differential diagnosis of osteoarthritis, rheumatoid arthritis, crystal arthropathies, Lyme's, hemochromatosis, SLE, cancer, or hematoma. So you need to evaluate all the things. You need to get an X-ray, ultrasound, and a full body profile, which includes CBC, ESR, CRP, CMP, anti-CCP antibody, and rheumatoid factor. Maybe we need to do ANA sensitivity as well. Now, when we do the X-rays and everything, we find the hand X-ray, which is consistent with osteoarthritis, joint spacing narrowing, and osteophytes, which are again consistent with osteoarthritis. She is radio RF negative, rheumatoid factor negative. So The patient's findings are suggestive of osteoarthritis. Now, osteoarthritis is a multi-joint involvement. You have joint involvement, knee, hip. You can have back involvement. You can have hand involvement. So it's age-related arthritis, and this is overuse arthritis basically. And these patients will have all other blood parameters which are normal. The joint spaces will be reduced in most of the joints, and these are the patients. Bouchard's notes, Heberden notes in the hand will again support the diagnosis of osteoarthritis. Now, what are the current options in her? So, the American College of Rheumatology and Arthritis Foundation guidelines first try to do psychosocial and mind approaches, relaxation techniques. You need to give them supportive modalities like a walker or a cane and instruct to walk with support. And physiotherapy is very important, mind you, because physiotherapy is one kind of therapy which will relieve most of the pain. It will increase the strength, it will increase the power of the muscles, and it will also help in the recovery of the patient per se and it will also help psychologically to the patient, and the muscular power will also increase, and the swelling inside the joint will also decrease with the physiotherapy. Not topical analgesics. So you can give them gels, and topical capsaicin gel is a local irritant. It is very helpful in treatment of localized pain symptoms. Now, if these are not successful, we can give them a oral NSAID therapy with selective COX-2 inhibitor like etoricoxib, because it has very less chances of any side effect, specifically the GI side effect and all other side effects which are related to NSAIDs. You can give them interventional procedures. Steroid injections occasionally, hyaluronic acid injections occasionally. But what I recommend is arthroscopy. So arthroscopy is a therapeutic treatment in which we can actually treat the problem, treat the arthritis, treat the meniscus problem. So whatever the mechanical problem is there, you can treat these patients with arthroscopic surgery. So that is very good in these patients with early onset of osteoarthritis. In late stages, we might need to do knee replacement surgeries for treatment of these problems. So there are 11 recommendations for MSK pain. You need to give them care that should be patient-centered. You need to identify the patients with high likelihood of pathology and red flags. Assess psychology. Radiological imaging, you need not to you need to just give basic radiology. Undertake a physical examination. Evaluate the patient with outcome measures, provide patient, educate them, give them full information. Physical therapy and exercise is very, very important. Manual therapy you can use as an adjunct. Non-surgical care should be given. You should try to resume continuation of work. Now, the key points of my talk are: chronic pain is a leading cause of disability in an adult population. Appropriate classification of pain is very necessary to proper management of symptoms. Now, clinicians must apply a systematic approach to the management of the patients. Thank you all for participation. Greetings from Dr. Prathmesh Jain and Team Advance at Ahmedabad. Thanks to Zydus for the support they are providing us for the academic activities. Thank you.